over in neurobehavioral health. And Anna has had me do this lecture for the last couple of years. I know a lot of the talks that you guys go through are really kind of geared towards board prep. And today we're really talking more about resources that are available for families and kind of knowing when to refer for psychological assessment and neuropsychological assessment. So this is kind of more about getting to know what services are available at the hospital, and then also knowing kind of if you go off to somewhere else, what to look for in those locations. It's always helpful for me to get a little bit of information from you guys about kind of where you're at with training and kind of what your plans are for after residency.
Well, we're both second years. I am still not entirely sure. I'm thinking either developmental, behavioral, or genetics, or possibly primary care. I'm still trying to figure that out.
All right.
Marcy, are you with us?
She might have stepped away for a second. So,
I think she wants to do emergency medicine, I believe.
So that's really helpful from my perspective. I think that we don't get a lot of referrals from emergency. And I'm getting a little echo, I'm sorry about that. I think that typically if someone comes through emergency that would be appropriate for our assessment purposes, they would probably get referred down the line from one of their specialty care providers who they would follow up with. So traumatic brain injury is a great example of, they would definitely be seen in the ED, but might not be referred to see us from the emergency physicians. Deanna, we definitely see a lot of referrals from genetics, and then also just from primary care. I think depending on the location of the clinic, kind of guides how many referrals we might get from them. Where are you each doing your Rex clinics?
I'm at the Akron East office.
Okay.
And I'm at Wadsworth.
Okay. Have either of you had to make a referral for a psychological assessment or for neuropsych assessment?
I don't think so.
Okay.
I don't think so.
I find that it's interesting. So I think sometimes we see a little bit of a difference in referral sources based on socioeconomic status. So we don't get a lot of referrals necessarily from places like Hudson or Medina, but like Locust Pediatrics, we tend to get a lot of referrals from a couple of physicians that are familiar with us, because I think sometimes those families may not be totally aware of oh, I'm sorry, my email is opening. Kind of what services are available and what to ask for. And sometimes our higher SES families may be more proactive in kind of seeking out referrals and kind of following up with the different specialty care providers. And so I think today what we'll really kind of talk through is just a little bit about the process of psychological assessment, so kind of what all it entails, and then times that it might be helpful for patients or families that you guys see. I think one other thing I always like to ask a little bit about before we get started is, how has the rotation been going so far? Which week are you guys in for DBQs?
We're in our second week.
Okay. Have you guys gotten to see any of the specialty clinics? Like specific?
So I've gotten to go to the Milo clinic as well as the NICU follow-ups, but that's about all I've done.
Okay.
Yeah, I've just done emergency follow-up so far. And then like regular DBP, but not specialty stuff.
Okay. For the NICU follow-up patients that you guys saw, did you get to, actually, did they do any testing or assessment during those visits, or was it just check-ins with the families?
I did see, I think they call it like the BIMS. It's like the more like the shorter, like kind of assessment of development. I did get to see that performed.
Okay.
And they kind of went over the longer one with me as well.
Oh, great. Okay, perfect. So I think that that's one of the things that's been a little bit unfortunate. I think the DBP's rotation has done such an amazing job of having things available virtually for you guys to participate in. But with the specialty clinics, I know a lot of those are trying to keep census low. So like for school success and for the autism clinic, they're trying to not have quite as many people with the families, just to make sure that we can socially distance and those types of things. So I think where there normally would have been a lot of opportunities to actually see a little bit of psychological testing in one of those clinics, that has been a part of the rotation right now that just isn't happening as consistently. So, but this at least will kind of give you an overview of which clinics are available and when might be good times to refer. So I'm gonna share my slides, and I'll send you guys a little PDF copy of these when we're finished with the talk so that you have access to them for future reference. So we'll try to make this conversation, also pop in with questions if you have any as we go through. One of the things I always like to point out as we're kind of getting started is that the psychological tests that we use are measurement oriented. So we use a specific test to get at a specific piece of information about a child, whether that is IQ or development or behaviors like an ADHD questionnaire. The psychological assessment is more problem oriented. And so it really involves pulling together a lot of different information. And some of that information will be psychological test scores, but we also rely a lot on information from the medical record and from the family. And the goal of the assessment process is really to have a better understanding of the child's functioning as it relates to different problem areas that the family might be having questions about. Psychological assessment ends up being a little bit different from a few other types of assessment that are available. One really good example of that is behavior assessment. And so behavior assessment is built on psychological principles, but it's really focused on looking very closely at specific behavioral patterns. And this works best actually when it happens kind of in the child's environment. So whether that be at school or at home, those are going to be the best place to do a true behavior assessment. Have either of you had a chance to rotate through or see the FCLC, the preschool that's associated with the hospital? So FCLC is a great place where behavior assessment is really effective. So if they have a child that's in the classroom and is having some type of problem behavior that's causing disruption to the learning environment, they can kind of have a psychologist come in that really watches the behavior, what happens before the problem behavior and what happens after, and how do we change that chain of event to help the child function better at school or at home. The multi-factored evaluations are what the school does to help children figure out if they're going to need an IEP. And these are sometimes called multi-factored evaluations, sometimes they're called ETRs or evaluation team reports. This also involves psychological testing, but these evaluations really focus on school performance and how different aspects of behavior or cognition might affect how the child is doing at school. One of the things that I always like to point out about school evaluations is that, especially here in Ohio, school psychologists are not allowed to diagnose. So they can qualify a child for services under a diagnostic category, but that child doesn't necessarily have that diagnosis. So I think a couple good examples of that, we'll occasionally see a child that's getting services under the category of autism, but maybe has never followed with developmental behavioral pediatrics or has never had a psychological assessment. And so they don't have a medical diagnosis of autism, which can make it hard for them to access the services that they need. Another, unfortunately, kind of common thing that we'll sometimes see is that I'll have an older child, maybe in middle school or early high school, that's coming in for an evaluation and the family's asking, like, always struggled with learning, I really don't understand why he's not catching up, like, what can we do? And then when I get copies of the school records, I see that the child has been qualified for services at school under the category of intellectual disability since they were quite young, but that was never really explained to the family and there's never been a formal diagnosis of ID. And so again, I think that it's really important if you're seeing a kid that families kind of concerned about something but haven't actually had a full evaluation, it may be helpful to do some additional assessment for them. The assessment process can kind of answer a bunch of different questions depending on what the biggest concern is for the child. I'm in neuropsychology, we're particularly interested in cognitive functioning, but we also look at behaviors and emotional difficulties. Personality is listed in this long list of different things. We don't spend a lot of time on personality assessment in kids because personality is really still developing. So this is not something that is as important for pediatric evaluations, but definitely is something that's often included in adult psychological assessment. The components of the assessment typically involve some type of formal testing, a clinical interview with the parent or caregiver, and with the patient. I always say that this definitely looks different based on the patient's age. So my interviews with my 5-year-old patients are going to be pretty quick, just checking in to make sure testing went okay. Whereas my interview with like a 17-year-old may be more comprehensive and look more like a true clinical interview where I'm asking a lot of questions about mood and trauma and things like that. We also include a behavior observation section in reports. And this is really important because there's so many different behaviors that can interfere with a child's performance on testing. And this also helps the parent or caregiver know if we had kind of a typical day with their child when they came in for evaluation, or if there might have been really unusual behaviors that don't normally happen because they're with new people or in a new environment. We have a smattering of boys often referred from DBPs who have a lot of hyperactivity and behavioral dysregulation. So if they're spending half the evaluation like under the table or running out of the room, we definitely want to capture that in the report, because if they get low scores, it might really just reflect that they weren't participating fully. And then we also have the parents fill out kind of standardized rating scales, and we try to get feedback from the teacher because the teacher spends so much time with the child. I think one thing that's really important to note is that our tests should never be used in isolation. And so occasionally I will see a report from an outside location that really focuses on one single test score. And I think a great example of that is the ADOS, the Autism Diagnostic Observation Schedule. So we often use this as a component for an evaluation of a child that's being considered for a diagnosis of autism. But it's really problematic if that score is the only thing that really gets focused on, because there's a lot of reasons that a child could have an elevated score on the ADOS. We see a lot of kids with social anxiety, and that can be a big reason that that score might be higher than we expect. So we really want to be thinking about a lot of different pieces of information and not just a single score. Have you guys had a chance to see an ADOS during kind of the course of your training?
No.
I think it's an interesting test. So it's adjusted for the patient's age and language abilities. And the activities are very play-based for younger kids. And then for older individuals, so older teenagers and adults, it's a lot of interviews. So kind of getting information about how they perceive relationships and how they navigate relationships. I think it can be really helpful information. And we have a ton of videos of these because we videotape all of the kids that come through our clinic and through the Autism Diagnostic Clinic. So if you guys ever have interest in watching some of these videos, we can definitely find some. They'll kind of show you what it looks like. The actual assessment report is going to include a fairly comprehensive history for the child, a review of the test data that's done during the assessment, clinical formulation, and then diagnoses when that's appropriate, as well as a recommendation section. My specialty is neuropsychological assessment. And so neuropsychology is really interested in looking at the impact of different things that happen to brain development and how those affect cognition and behavior. So really thinking about things like prematurity or in utero exposure, also thinking about more acute type injuries, so traumatic brain injury or kids that are diagnosed with brain tumors. Those would be groups that we would be really interested in seeing what the impact of that condition is on how they're functioning. We spend a lot of time in neuropsychology and psychological assessment thinking about normal variations in development. I think a lot of times we do a lot of education with families about what typical skills should be at different ages. I've had a smattering of families that come in with a three and a half year old saying, my kid definitely has ADHD. And so that ends up being a discussion about the fact that attention span is extremely variable in kids that are under the age of 5, and that I'm really hesitant to diagnose ADHD in kids that young because I want to give them a chance to kind of grow and develop. And a lot of the kids that we see, if they do have any type of developmental delay related to how their brain is developing, this could be another reason that they might be having more attention problems when they're compared to peers. So really thinking about that normal variation in development, as well as whether they're seeing problems with acquisition of skills versus an actual decline or regression in skills. We talk a lot in neuropsychology about different cognitive domains, But down in the bottom corner, you see those kind of overlapping circles. And that's really much more reflective of how our brain works and how these different cognitive abilities work together. This, I think, is really important for when families are talking about different concerns that they may have. It's really common for families to come in complaining that their child is having memory problems. But when we ask detailed questions, a lot of times that comes back to attention, that if the kid isn't focusing, it's really hard for them to remember information later. So that can be something that we can really educate families about and help them kind of figure out ways to prompt attention before they're telling an instruction or telling something they really want the child to learn. Another aspect I think that really affects all areas of development is that we are such a verbal society. And so when kids have language disorders or delays in language development, we can see deficits in a lot of different areas because so much of our instruction is verbal. And so for those kids, they're really missing out on a lot of learning in different areas because they don't understand the verbal input. The psychological and neuropsychological tests that we use are interpreted using norms, and the norms are based on age, sometimes based on sex, and then sometimes based on education. For most pediatric evaluations, age and education are closely correlated, so we often don't have to account for both of those, but for adult assessments, it's really important to have norms that take into account education. So we wouldn't want to compare a 35-year-old that only completed 8th grade to a 35-year-old that had a medical degree. So for that reason, we end up having these stratified norms. Historically, a lot of the tests that we use were really designed and normed on higher to middle class SES and typically Caucasian families or Caucasian children. So I think over time, our test developers have gotten better about having samples that are more representative of the United States population, but there are still concerns about cultural bias with some of the tests that we use. So thinking about dominant-handedness in education is really important when thinking about how well does this test really reflect what I should see for my patient. A couple of good examples about cultural bias that really affect the kids that we see in Northeast Ohio. We have a lot of limitations with what we can do with our Nepali refugee families. So if we have a Nepali family that the child has learned English and is being educated in English at school, we can do some testing with that child, but I always include kind of a caveat that the tests that we use are designed for English as a first language learner and not for children that are learning English as a second language. So there's a natural kind of disadvantage that they have on the tests that we use. It's really difficult to use an interpreter to translate the tests that we use because it's hard to know if words that are common or easy items in English might be less common and not as easy in Nepali. So you can't directly equate the questions and the kind of ability level it takes to answer the questions by just translating them. So we have a lot of limitations when it comes to that. The scoring metrics that we use, so most reports, that if you were to send a patient for testing and get a report back, there should be some type of little key at the back of the report with all the scores that tell you the mean and standard deviation for each of the assessments. So one really common measure is a standard score, and this is what we use for things like IQ. And so these have a mean of 100, and anything between 85 and 115 is broadly average. So sometimes when I'm talking to families about test results, I'll pull up a bell curve and kind of explain to them, really what we want to see is scores in the average range. Some families really don't like the word average, so they kind of get flustered, like thinking that that's not necessarily where they want their child to be. But for us, 68% of the population kind of fall in that tall part of the curve. And so that's really what we're looking for. And we don't really get concerned about deficits until we start to see patterns of scores that are falling below that bottom green line. Other common types of scores are T-scores, where an average score is 50, and anything 40 to 60 is broadly average, or scaled scores where an average is 10, and anything between 7 and 13 is broadly average. So in thinking about when might be a helpful time to refer a child for psychological assessment, I think anytime you're seeing a kiddo in clinic that has potentially kind of complicated deficits that the family is reporting, whether that's with cognition, school functioning, kind of overall development, those might be appropriate times to send for testing. And I think we can be particularly helpful if you have a child where there's some kind of diagnostic question that you feel like you don't have enough time to answer in a clinic visit. I think ADHD is a really good example of a diagnosis that probably 95% of the time can be easily diagnosed and managed in the pediatrician's office. But I think there is a subset of kids where it's kind of borderline symptoms or concerns, is this ADHD versus anxiety, where sometimes getting some additional testing can be really helpful. I also think that for autism evaluations, often involving a psychologist can be really helpful just because we tend to have a little bit more time with our evaluations, and that kind of opens up opportunities to get as much behavioral data as we can to really help us with that diagnosis. One other place that I think that the additional testing can be really helpful is if you have a family that's coming in and just really saying, school isn't going well, my child isn't learning the way that they're supposed to, their IEP doesn't seem to be helping. Sometimes in those cases, that can be a really helpful time to refer for additional testing. And then in thinking about psychological assessment versus neuropsychological assessment, we at the hospital have fairly strict criteria for kids that are coming through neuropsychology. So for our clinical purposes, we bill under medical diagnoses. And so there has to be some type of medical or neurologic condition that we would be assessing to see how that's affecting the child's functioning. So I would say our most common patient populations are epilepsy, traumatic brain injury, and then our kind of hematology oncology patients. And we see both brain tumor patients, but also kids that have had intrathecal methotrexate or other types of chemotherapeutic agents for things like ALL that might affect cognition. We can also look at other types of medical conditions that impact cognitive functioning. This is a lot more common in adults, but some older adolescents that have really poorly controlled diabetes, we can start to see some cognitive impact from that. We also see patients with sickle cell disease. They're at risk for having kind of mini strokes, and then also just for missing a lot of school related to pain crises. So those are all kind of things that we could kind of see and evaluate for. I guess the other population that I mentioned earlier, we see a lot of kids that were born prematurely or kids that have had some type of in utero exposure. And the preemies, we tend to see them kind of after they've transitioned out of Dr. Lingkamp's NICU follow-up clinic. So we tend to see those kids as they're getting older and they're starting to see more kind of cognitive difficulties related to the prematurity. In outside places that are not at the hospital, there may be a more flexibility in the types of assessment that are available. So there are a lot of private practice neuropsychologists that will take all evaluations. So some of my colleagues that are in private practice would see just a straight ADHD type evaluation. And at our hospital, there's kind of another clinic that might be more appropriate for that child. In neuropsychology, we also get asked to look at some other things related to injury, and one of those is symptom exaggeration. For adult assessments, symptom exaggeration tends to be more intentional. So if we have an adult that might be seeking compensation from an accident, or if we have an adult that's trying to get Social Security disability income, there might be reasons for them to come in and try to look worse on testing than they're actually doing. For kids, symptom exaggeration tends to be more a manifestation of kind of how they're feeling or overall functioning. And so we can sometimes get kids that don't try hard when they're having really bad headaches or if they're really depressed. So we try to look at effort when we're doing testing to make sure that we're getting good and valid data. We also sometimes get asked to look at functional implications for different types of injuries and kind of thinking about what is going to happen when the child turns 18 and transitions to adulthood. Are they going to be able to be independent? What do their self-care skills look like? And so we can be really helpful in kind of those types of planning situations. When you're thinking about referrals, I think the more specific you can be, the better able we are to help. So I think one of the helpful things is because our evaluations tend to be fairly long, is that we can typically answer more than one question. So if you have several diagnoses that you're concerned about for a child, be sure to let us know about that. And I think just providing as much information as possible helps us kind of shape the evaluation and make sure we can be helpful for the family. I think it's also really important to talk to the family about why you're referring them. We will, and this happens less often than when I was in training in another state, but we would occasionally get referrals where the referring provider was very concerned about autism, but they hadn't raised that with the family. And so the family was kind of coming into the evaluation not really knowing why they were being sent. And that becomes a really difficult and kind of tricky conversation. So we want them to kind of be prepared and able to kind of know what they're coming in for. I think it just is helpful for everybody involved. This just includes a lot of different kind of specific types of referral questions. So thinking about if you have a medical or neurologic condition, what you might want to be looking at for that. Thinking about specific cognitive areas that families might be complaining of being impaired and why that would be a reason to send them for assessment. We don't do a lot of assessment on the inpatient floors at Akron Children's, except for we have some involvement in inpatient rehab. One of the reasons for that is I tend to find that families that are in the PICU often are just in such crisis mode that any type of testing that we could do probably wouldn't be very valid. So it's much more helpful to have more of a consult liaison model where they have someone they can talk to and kind of figure out if additional testing might be needed after discharge. But testing on the unit probably is not going to yield a great result. On the inpatient rehabilitation unit, we tend to do serial assessments where we look at improvements in cognitive function for kids that have had a central nervous system injury. And often this tends to be a little bit more qualitative than some of the testing that we do in outpatient setting, because often kids are having so much significant impairment shortly after the injury, and then hopefully seeing some rapid recovery over time. And then I think another thing to be aware of, there's a lot of opportunities for families to get psychological assessment outside of the hospital system. I think for families that are complaining about school, starting with the school is a great place to begin. I think really having the school take responsibility. Have either of you had a family that needed help kind of getting the IEP process started? So I think Marcy's shaking her head yes, and you shaking your head no. So I think this can be really tricky, that sometimes families are not as familiar with their rights through the school. And so if a family is really concerned about how a child is progressing, it's well within their right to request that the child be evaluated for an IEP. And we always encourage families to request that in writing so that way the school, it starts a time frame from the school to respond to that request. Often the school, so I say pre-COVID, often the school would be able to do evaluations faster than a child might get in for an outpatient assessment. And so really starting there may get the process going. And then if there are still ongoing concerns, you can make a referral for additional testing. Sometimes it may be helpful even to start both things at the same time and kind of see which one works out faster, just so that the child's not missing opportunities for intervention. And then there are a lot of private practitioners that do psychological and neuropsychological testing. I think that one of the disadvantages is that they don't always take all insurances. And so sometimes, especially for our families that are on Medicaid, they may not have as many opportunities for those types of private practice assessments, whereas at the hospital, we obviously take all insurance. So they're definitely going to have access, even though sometimes our wait lists can be longer. And then in thinking about kind of how the information can be helpful, obviously, if we have concerns about a specific diagnosis, we'll go ahead and make recommendations, or at least occasionally I'll see a child where it's a little bit unclear. And so there might be a time where I would give a provisional diagnosis or defer a diagnosis until we have more time to kind of collect data about the behaviors. But I think we really also try to take a strengths-based approach. So kind of thinking about what areas is the child doing best in, and how do we use those strengths to help them in other areas where they're struggling. One thing that can be really helpful is making sure that we're kind of providing that medical home experience. So really coordinating and working with the referring provider to make sure that the child has access to all the resources that they might need. And then we don't do a lot of treatment, and our assessment psychologists don't do a lot of intervention, but we really help families get linked up with any type of mental health treatment that they might need, either within the hospital or outside of the hospital. We also try to make some recommendations specifically for the family. So thinking about what things might be helpful for the child at school, and then giving parents or caregivers some resources if they're having problem behaviors at home. How do they address those and be able to feel like they're functioning more fully as a family? So here at the hospital, we have in the NDSC, we have neurobehavioral health, and there's 3 different kind of branches of assessment that are available in our group. So we recently hired 2 new neuropsychologists, so we now have 4 neuropsychologists in our team. We have Dr. Lieb's Autism Diagnostic Clinic that's multidisciplinary, and then School Success Clinic, which is also multidisciplinary. And then Dr. Putt, who you may have already met him, but if not, I think he'll be giving a lecture at some point during the time that you're with DBPs. He has an ADHD clinic that's down on the 2nd floor of Considine in the psychiatry psychology department. And his clinic is really helpful, again, for those kind of tricky cases where it isn't so clear cut, or maybe the school is reporting a lot of concerns, but the parents aren't reporting concerns. He can kind of do additional testing to see if there truly are kind of these underlying attention deficits. Now we went through that kind of quickly. I have a case that we can talk through, but I wanted to check and see if you guys have questions so far. Okay. So I picked this case because this is an example of how we rarely have kids that come in where it's just one thing that's problematic or concerning for the family. So this case was one that I saw shortly after I finished fellowship, and he was a 14-year-old male referred to us from neurology. He had been riding an ATV. The family lives in kind of southeastern Ohio, so he was out in kind of a rural area, and he flipped the ATV. So there was a really big question about loss of consciousness because they didn't find him for a little time. And so he was really confused when they found him, and they don't know how long he actually lost consciousness. But he did have post-traumatic amnesia that lasted for several days. Interestingly, his imaging findings were negative, and so the neurology team had kind of vaguely classified his injury as kind of a mild to moderate TBI. So he didn't neatly fit into the mild TBI category, but there were some characteristics that also weren't quite moderate. So that was kind of how they termed his injury. After his TBI, he was having really terrible headaches and what the family termed memory problems. And he'd been out of school for months. So what the family reported to me is that every time they would try to get him back into school, he would be really overwhelmed by the amount of makeup work that he had to do. His headaches would just escalate to the point that he was having nausea and vomiting at school, and he would come home. And after a couple of tries of trying to get him back in school, he just refused. And he was a kind of a large guy. So I think he was probably close to 6 feet when he was 14. And mom was just concerned that he's getting to the point that I can't force him to go. I can't physically make him go to school. His TBI was complicated by the fact that prior to his injury, he had a really extensive psychiatric history. So he was being followed by a pediatric psychiatrist, by an adult psychiatrist in southeastern Ohio, who had diagnosed this kid with ADHD, ODD, conduct disorder, and bipolar disorder. And was currently treating those symptoms with risperidone and Topamax. So this was all occurring before the TBI happened. When I read this patient's chart kind of in preparation for the evaluation, I was really concerned about the fact that he might come in and just not want to be there, might not want to do testing because of all the school refusal. But he really surprised me, and he came in and did really well on the measures of effort that we include throughout the day. And so the effort tests that we use are tests that are designed to seem harder than they really are. And when you have a patient that performs poorly on these effort tests, it tells you that they're giving suboptimal effort. So really, in a lot of cases, they're almost performing below chance on some of these measures. And that would tell you that there would be something that was just off about the way that they were approaching the testing. But he did great on those. His overall intelligence was evenly developed with intact verbal and nonverbal reasoning abilities. And his academic skills were kind of low average to mildly impaired, which was very consistent with mom's report that he was a kind of B to D student. So never really great in school, but never really motivated in school either. The most problematic areas on testing were that we saw really significant deficits in attention and executive functioning abilities. So his processing speed was extremely slow. He had a lot of difficulty with working memory, and then poor visual attention and difficulty with cognitive flexibility, which is kind of the ability to switch between different activities or holds two rules in mind and be able to follow both rules. The attention deficits that he was experiencing really affected his ability to encode or learn new information. And so his performance on verbal and visual memory tests was really low. But what was interesting is that the small amount of information that he did learn, he would hang on to that. So that really helped us to understand that it wasn't a memory impairment, but it was just that the attention deficits were so bad, he wasn't able to learn as other kids his age were. So the way that I kind of looked at his data is that we can definitely see some attention and processing speed difficulties after a mild to moderate TBI, but for this patient, the degree of impairment was more than expected. And so that likely reflected the fact that even before his injury, he probably had some mild difficulties in these areas, and these were just worsened by the TBI that he sustained. One of the other things that I really talked to the family about is the fact that Topamax has a lot of cognitive side effects. So it can result in fluid processing and memory impairment. And so we really talked about the fact that probably the way his symptoms were being managed, especially, were not very helpful as he was trying to recover from this brain injury. And so in my report, I spent a lot of time talking about accommodations that would help him get back to school. So we made a plan where he was going to go back part-time and kind of build up to being able to tolerate full days, and really worked closely with the school to help them reduce his workload. So thinking about the fact that he's missed a lot of instruction, we want him to get caught up, but we also don't want him to be so overwhelmed by the homework that he just refuses to go to school. The other big recommendation that I made for him was really wanting to get him linked up with a pediatric psychiatrist who I felt like would have a more nuanced understanding of some of the behaviors and can provide some updated recommendations regarding medication management of symptoms, and then getting him linked up with therapy and counseling services. This was somewhat challenging because they did live in a rural area, and so it can be hard at times to find high quality treatment for kids that are in these kind of outskirt areas. But the mom was really motivated with wanting him to be able to go to school more consistently and for him to graduate. So they really worked hard to find a therapist that would work with him. And that's the presentation. Any questions about that? Anything that kind of comes up, either patients that you've seen or questions about when would be good times to refer?
What's kind of a typical timeline for follow-up? Like if we do place a referral?
That's a great question. So in neuropsychology, historically, we schedule about 6 months out. And we typically, those slots are typically booked, and then we typically have some amount of a waiting list that we were being scheduled by centralized scheduling. And so during that time frame, we kind of lost track of what our wait list looked like. What I typically tell referring providers and families is that when you place a referral, I would actually encourage to give the number and have the family call when you place the referral. If the family waits for us to call, I think it tends to be a longer time frame for them to get an appointment. But for neuropsychology, and I'm hoping with our new providers that wait list will be down a little bit, but I would say probably for most people, probably 6 to 12 months. And then COVID also kind of messed things up for us. So we had a period from March through the end of April that we just weren't seeing patients in person. And so as a result of that, it really kind of increased our waiting list, but we tried to see extra patients over the summer. But I know like for School Success Clinic, that has really created a backlog for their waiting list. And so I think probably to get into School Success is at least a year wait list right now. So I think it kind of depends on the clinic, but if you ever have questions, feel free to reach out to one of us and we can kind of help figure out and triage I think another issue that we've had with centralized scheduling is that for a while, they weren't always sure which clinic was most appropriate for a family. And so we have actually are kind of in the process of taking back our scheduling because we were having so many issues with that. And so my hope is that moving forward, our kind of internal scheduling team will be better able to help figure out like which clinic might be most appropriate. So a good example of that, we had a referral recently where the kiddo was referred to School Success, but as they kind of got their intake packet back, it turned out that the child was born prematurely and also had a history of in utero exposure. And so for School Success, if there's any of those type of medical or neurologic concerns, they will kind of route them to us. So that kind of ended up for the referral getting switched over to our service. So that's kind of how that works. But yeah, we're happy to answer questions. If you ever have a patient that you're kind of trying to figure out like who might be best to see them, feel free to shoot me an email or we can set up a Teams meeting to kind of chat about it.
Thanks.
Yeah. So talking about some of those like genetic conditions that you would then, see the kid, would you have like, so I'm trying to think of a way to phrase this. So in your opinion, as a neuropsychologist, should those patients be automatically referred to you guys or only if they start to have issues? Because for instance, like with Turner syndrome, there's a huge spectrum.
Yeah, that's a great
as far
point.
as like, have NLD versus not. So would you just refer any girl with Turner syndrome for just as an example, or any child with Down syndrome, for instance, or would you wait till there were issues?
So it's interesting because I think there's like two trains of thought. I think that there's some people that would say just refer right away, and that way we can kind of hopefully catch things early. I've also, it's interesting, I help have a consultative role in Dr. Corman's tuberous sclerosis clinic. And he definitely takes the approach of we should wait until there are problems because like we don't want to just be creating basically like burden for the family with the number of assessments and testing that they have to go through. So I think it may depend a little bit on the population. So and Turner syndrome is a really interesting one because for a while, and I hope that we get back involved in this, but one of our neuropsychology colleagues was actually going and kind of being available as a consultant during the clinic to kind of make sure that they're asking questions about math difficulties because these girls are really at risk for having a lot of difficulty with math and kind of seeing if there's anything that's subtle but might be coming up about attention span or things like that. So I think my thought is probably waiting until the family has some level of concern may be helpful. There are definitely some other populations that we see a little bit more preventatively. So thinking about our craniosynostosis babies and cardiac babies, often we're trying to see those kiddos, the craniosynostosis, we try to see pre-surgically and post-surgically just to evaluate for any kind of impact from surgery and make sure development hasn't been affected. And then the cardiac kids, we're often seeing them serially, so really following them over time, just because they are at risk for not only developmental delays, but later cognitive impairment because of the anesthesia and the kind of lack of oxygen that may happen based on their cardiac defect. I think the other thing with the genetic conditions is that there are some genetic conditions that don't have an associated kind of cognitive pattern. And so for those kids, it may be less helpful, but if a family is reporting concerns, I think definitely sending them our way can be helpful. Unfortunately, we don't get to see a lot of the Down syndrome kiddos. I think that often, I should say that there's more variability, I think, in cognitive abilities, but often the schools are doing a lot of just intelligence testing and adaptive testing. So they may not need as much of a comprehensive evaluation kind of outside of their typical school follow-up, which is, I love those kiddos. It's unfortunate that we don't get to see them very often, but yeah, those are great questions. I will send you guys the email with the slides, and that way you'll have my contact info. So if you ever have questions about a patient or referral, definitely send me a message and I'm happy to help with that. All right.
Thank you so much.
Yeah, thank you guys.
Thank you.
Bye.